Let's study about the snake bite. 1,25,000 deaths annually worldwide occurs because of the snake bite. 400 to 3,000 snake species are poisonous. So types of snake bites are two types of the snake bites are there. Okay, snake bites are two types. One is business bite, second is defensive bite. In the defensive bite, we have two types of the venomous bites, that is hemotoxic and as neurotoxic. Both hemo and neurotoxic is Russell viper. Russell viper is both hemotoxic and neurotoxic, whereas hemotoxic is saw-scaled viper. Saw-scaled viper is hemotoxic. Other snakes such as cobra and krait, both are neurotoxic. So this is the basic differentiation between hemotoxic and neurotoxic. Coming to the clinical features, by this diagram you can understand the clinical features. Here there are neurotoxic clinical features, here hemotoxic and local strike, that is local symptoms and signs. So first, after the bite, the body's first response is nausea, vomiting, abdominal pain and persistent headache. There can be intense pain at the bite site, blistering, tissue necrosis, prominent fang marks and ground zero, that is local site reaction can occur. Early clues of severe envenomation is rapidly spreading swelling, tender lymph nodes and spontaneous bleed. And snake proved to be very dangerous. So these are the early clues of severe envenomation, that is snake identifies as very dangerous: rapid spread of local swelling, tender enlargement of lymph nodes, early systemic symptoms, early spontaneous bleeding and dark urine, which are described here. Now we have discussed about local manifestations, then body's first response, early clues of severe envenomation. There can be total system collapse by rhabdomyolysis. There can be rhabdomyolysis presented as muscle pain and dark urine. Acute kidney injury or acute kidney failure can occur. Hypotension can occur. Myocardial toxicity can occur. Coming to the neurotoxic clinical features, which is by cobra and krait. There is bulbar palsy, generalized muscle weakness, ptosis and diplopia. So these are neurotoxic clinical features. Coming to the hemotoxic features, intracranial hemorrhage can occur, gum bleeding and epistaxis can occur. These are coagulopathies. One is neurotoxicity and then coagulopathy, system failures. Coming to the investigations. Investigations will do CBC, and since there is kidney injury, urine analysis, electrolyte, BUN and creatinine kinase we can send for the investigation. Since there is myocardial toxicity, ECG can be done. Since there is bleeding manifestation, that's why 20 minutes whole blood clotting we can do as investigation. Coming to the general approach, the steps in the management are: first aid treatment, transport to the hospital, rapid clinical assessment and resuscitation, then detailed clinical assessment of and species diagnosis, investigation, antivenin treatment, supportive treatment, rehabilitation and treatment of chronic complications. In the subsequent slides, we will discuss about these steps in detail. First aid treatment. Okay, first of all, first aid treatment, that is do it right. by this mnemonic you can remember first aid treatments. Which are the first aid treatment? R means reassurance and immobilization. Reassure the patient and immobilize the limb in a functional position below the heart level. During the transportation to the hospital, to prevent the absorption of toxin, a tourniquet can be applied proximal to the bite site about 5 cm above the upper limit of the swelling, which allows one finger beneath, which it should be left till the anti-snake venom is administered. Next, GH means get to the hospital. In the right we have RI, that is reassurance and immobilization. G for get to the hospital. Immediately transport the patient to the medical facility. Avoid the ineffective treatments like sectioning and incision. T means tell the doctor about the symptoms and as well as the snake. So this is about the first aid treatment. Coming to the transporting to the hospital, as we have discussed here, transport to the hospital, get to the hospital, in the right only, these two are done. Rapid clinical assessment and resuscitation. When the patient comes here, the doctor will do rapid clinical assessment and resuscitation, that is also done. Detailed clinical assessment, since he is taking the history, detailed clinical assessment. Antivenin treatment. Now coming to the ASV therapy. Principles of ASV therapy: neutralizing the venom load, that is 8 to 10 vials of ASV are typically required to neutralize the average venom dose. Since Russell Viper, for example, 63 mg venom per bite it releases, one vial of ASV can neutralize 6 mg of Russell Viper venom. So that's why initial dose is 8 to 10 vials of ASV, because 863 divided by 6 is approximately 10 vials of ASV. So that's why initially we will give 8 to 10 vials of ASV. Indian polyvalent ASV coverage. The ASV is Indian, it is restricted to the polyvalent venom, that is to the vipers and cobra, crate. It is against these 4 common snakes. Administration and sensitivity testing. Administer IV over 1 hour. Check for the hypersensitivity via skin and conjunctival tests. Total range of venom injected by all species is 5 to 147 mg. So that's why maximum 25 vials of polyvalent ASV can be given. So before giving this anti-snake venom, you have to do skin test and conjunctival test. How do you do skin test? By intradermal injection of 0.1 ml of 1:100 saline dilution of AVS. That means one quantity in 100 ml of NS, you will put 1 unit in 100 ml of NS. This preparation 0.1 ml you should give in the intradermally. So that's how you will do skin test. If the wheal is more than 10 mm in 10 to 30 minutes, then it is positive. Coming to the conjunctival test, by instilling 1 drop of 1:10 saline. Now one part in a 10 ml of saline, that is 1:10. Earlier in the skin we used to give 1:100. Here it is 1:10 normal saline. In the lower conjunctival sac, hypersensitivity is indicated by development of the conjunctivitis and tears in 10 to 30 minutes. Both 10 to 30 minutes you will do. Both skin test and conjunctival test, both 10 to 30 minutes. But here in the conjunctiva, conjunctivitis can occur and tears will come. But here wheal will form. In the skin test we use 1:100 of instillation, here 1:10 of instillation. ASV can be given within 4 hours, up to can be given in 3 weeks if there are hemostatic abnormalities. Antivenin should be given over 1 hour. So this is graphically presented here. Maximum dose 25 vials within 4 hours, can be given 2 to 3 weeks if hemostatic issues are there. Observation of clinical responses. So after you after you give ASV, you should have these clinical responses, that is within 15 to 30 minutes. Within half an hour you should systemic bleeding should stop, that is initial recovery. In 1 hour the heart rate will increase and blood BP should increase. In 3 to 9 hours coagulation correction should occur, clotting functions and coagulation dysfunctions are expected to return to the normal in 3 to 9 hours. So within half hour the bleeding should stop, within 1 hour BP and heart rate should increase, within 3 to 9 hour the coagulation correction should occur. So these are the observation of clinical responses. Here we have seen first aid, here we see principles, and then observation of clinical responses. So in the general approach we have seen first aid and transport, that is do it right, mnemonic, and rapid clinical assessment and detailed clinical assessment, investigation by the doctor, then as a treatment, antivenin treatment, supportive treatment, rehabilitation and treatment of chronic complications. Chronic complications, what are the chronic complications? You see chronic complications like there can be infection, there can be gas gangrene, there can be electrolyte imbalance, there can be kidney injury as we have discussed here in the clinical features, there can be so many rhabdomyolysis, hypotension, so many things. So those chronic complication we have to manage. So for that, general supportive measures, broad spectrum antibiotics, prophylaxis against the tetanus, and gas gangrene, FFE, platelet, PCV, transfusion can be done, restriction of fluids, electrolyte dialysis in acute renal injury, surgical debridement can be done in the gas gangrene. Coming to the snake bite proper management algorithm, in suspected cases of snake bite, suppose a patient has come with a snake bite, then systemic envenomation is there present, then hemotoxic snake bite or neurotoxic snake bite, we have to differentiate. If it is neurotoxic and there are neurological symptoms like ptosis, respiratory weakness, as we have discussed above in here clinical features, here you see ptosis, diplopia, bulbar palsy, generalized muscle weakness, these are neurotoxic clinical features, whereas hemotoxic clinical features are glum bleeding, ICH, that is intracranial hemorrhage, epistaxis. So these are the hemotoxic. Suppose neurotoxic features are there, then 8 to 10 vials of ASV followed by 10 vials within 1 to 2 hours. If no or a complete response, incomplete response, then within 1 to 2 hours you have to again give ASV. First you have given 10 vials, right? Then again after 1 to 2 hours, if there is incomplete response, again you can give 10 vials. This is in case of the neurotoxic. Suppose if it is hemotoxic, progressive cellulitis is there, WBCT, that is whole blood clotting time is more than 20 minutes, spontaneous bleeding is there, then first you will give as basic 8 to 10 vials of ASV followed by 5 vials of ASV within 6 hours if WBCT, that is whole blood clotting time is more than 20 minutes. Maximum you will give 25 vials. So here in the neurotoxic you have given 8 to 10 vials first, there is no resolution, then again you have given 10 vials in 2 hours. But here 8 to 10 vials you have given in a hemotoxic, then within 6 hours you will give 5 vials, maximum of 25 vials. So that is the management of snake bite. Here we have recurrence that can occur in 24 to 48 hours. So this is the management of snake bite. Let's revise. Snake bite, these are two types of the bite, business bite and defensive bite. Defensive bite we have neurotoxic and hemotoxic. Hemotoxic and neurotoxic clinical features are hemotoxic, epistaxis, gum bleeding, intracranial hemorrhage, and clotting time is increased. Neurotoxic we have ptosis, diplopia because of the cobra bite, bulbar palsy and generalized weakness. If the snake bites, then body's first response can be this nausea, vomiting, abdominal pain, persistent headaches. Early clues are rapidly spreading swelling, spontaneous bleeding, tender lymph nodes, and dangerously identified snake. The local alarms are intense pain, blistering, tissue necrosis, prominent fang marks, and local site reaction. So these are the clinical features. Coming to the general approach, we have first aid treatment and transport to the hospital by, you can remember by the mnemonic, do it right, and then rapid clinical assessment, detailed and clinical assessment, species identification, investigation done by the doctor, antivariant treatment, ASV. ASV, we have discussed about the principles of ASV, that is 8 to 10 vials initially you have to give, maximum of 25 vials within 4 to 4 hours till 3 weeks you can give. So that is ASV management. Coming to the supportive treatment, rehabilitation and treatment of the chronic complications. To treat the chronic complication you can do debridement, antibiotics, and TT injection, gas gangrene prevention. So all these are the chronic complications. Coming to the observation and clinical response, within half an hour the bleeding should stop, within 1 hour BP and heart rate should increase, within 3 to 9 hours coagulation correction should occur. Coming to the systemic envenomation and local envenomation difference, just look at this. In the systemic, hemostasis, neurotoxicity, cardiotoxicity, renal failure, urine and lab evidence, this is systemic envenomation. Local envenomation, there is half of the bite. In the local swelling, there is local swelling involves half of the bitten limb and swelling after the bite, rapid extension and lymph node, as we have discussed here. Next, coming to the principles, as we have discussed above, 63 mg of venom per bite, 6 mg per vial, we have 6 mg of Russell Viper neutralization. So that's why 8 to 10 vials of ASV will give. And coming to the management algorithm, hemotoxicity, 8 to 10 vials you will give initially, then 5 vials, maximum of 25 vials. In the neurotoxicity, 8 to 10 vials, then again 1 to 2 hours, 10 vials you will give.